Okay, I think Tom's made a pretty good case there for the supine position. It sounded to me like it was highly dependent on using ultrasound, and that was the basis for the argument for the thing. So you've got to learn two new things: how to do ultrasound, and then how to do supine. So let's have a look at the traditional approach here, the prone position, and we'll try and look at a few facts too and some comparisons between these two positions. So. When PCNL started out, of course, it was all in the prone position, and if you talk to Arthur Smith and Ralph Klayman and others who started this operation and asked them, why are you putting the patient in the prone position? The simple answer was that the kidneys are at the back, and the easiest way to get in the kidney is to go through the back, therefore the patient has to be in the prone position. But there were some other, medical reasons they thought of that as well. It was thought it would be safer. You're going through perhaps a less vascular part of the kidney, decreased risk of colon injury, better access to the lower pole, and better for doing flexible nephroscopy, that you're going to have more through and through irrigation and be able to see better. If you talk to the supine position, Tom's made some of these points, but not all of them. Most people will say it's faster, that you only have to drape the patient one, you're not in lithotomy and then having to turn the patient over, obviously, if you're supine. So reduced OR time, better control of the airway from the anesthetic point of view, less risk perhaps in obese patients and those with COPD and so forth, and that you can do ureteroscopy and percutaneous surgery at the same time. So those are all the things that have been touted for advantages. If you want to buy a Volkswagen, I guess you can buy one that's upside down or straight up. Maybe they both work, I'm not quite sure. If you want to build a house, you can actually build a house like this, and apparently it works out pretty well to have a house that's upside down. And if you live in Canada and want to make snowmen, you can actually make a snowman quite well, works very well, looks good, it's kind of exciting, and it just happens to be in the upside down position. So the line I took away from Tom regarding supine position is we don't know what we're talking about. And actually, he said that twice. And I agree, it's hard to tell what we're talking about when people say supine position. There's at least a dozen things that mean supine position. Could be the flank cup just a little bit, Valdivia, totally supine. So I think one thing is we have to define really what are we talking about when we talk about supine position, because there's a whole lot of different things that are described. So some of the initial series that looked at this, Steele and Marshall out of Australia, I think we were all shocked that there were no colon injuries, that people weren't getting in and out of the colon, but it looks to be true. Pretty good stone-free rates, and proved to us that you could actually do a supine PCNL pretty safely. One of the other earlier studies that came along, and in this one they actually showed they could do it faster, so it was more rapid PCNL, saving time compared to the prone position, with the other metrics of transfusions and stone-free rate and so forth being pretty much the same. One of the first randomized trials, and again some of the metrics the same, stone-free rates, blood transfusion and so forth, and again it was faster if you put the patient in the supine position for the reasons I've described. So this is how we do our perks. The patients are directly over prone, and the fundamental piece of this is using the flexible cystoscope to put up the initial ureterocatheter and the guide wire. So you don't have to start out in a lithotomy position and transfer the patient over. They go asleep, they're totally prone, use a flexible scope. So the whole time difference thing goes away if you're able to use a flexible cystoscope. If we transition then to look at some more modern studies that have compared these two positionings, what John de la Rosette found there was a higher transfusion rate when the people were in the supine position. And their conclusions for this is that maybe supine's okay for small stones, but for larger stones, you're probably still better off in the prone position. De la Rosette went on further. This is the Crows study, and some very interesting results here showed that the OR time was actually shorter in the prone position. The stone-free rates were better in the prone position. lower rate of failed access if you're in the prone position. And overall, they felt they would like to stick with the prone position, that it was better. The transfusion rates were a little bit more, but not statistically so. Went on further from the Crow study to look at staghorn stones. Same thing here. It was actually shorter operating room time in the prone position compared to the supine position. Easier access into the lower pole and better stone-free rates in the prone position. One of the main things that, as I've watched people working in the supine position, you seem to have a much narrower window to put in the tracks. And if you're in the prone position, you've got a wider opening between the iliac crest and the 12th rib, more room to put in the tracks, and that's, I think, one of the key advantages of it. And actually, I think this has been kind of proven, if you like, with imaging. If you look in CT scans, you actually have a greater window to get into the kidney when the patient is in the prone position. And the track lengths are actually shorter as well when you put the sheath in when the patient is prone. The upper pole, and Tom conceded this, that it's much easier if you're in the prone position. We use a lot of upper pole access. It's great for staghorn stones, and overall easier to do if you're in the prone position. I suppose if you've got a ureteral stone and a stone up in the kidney, if you're supine, perhaps it's easier to do the whole thing. But if you position the patient like this, split leg, you've got good access to the ureter, you can do a ureteral stone, still do a prone perc, all under a single anesthetic. So we'll just finish off quickly here a few other points. Prone is very popular, so around the world, 80–90% of people, just like this audience, tend to use the prone position. And again, if you're basing it on ultrasound, you have to learn two new things, both ultrasound and then how to work in the supine position. There are several studies. I've already quoted a couple. Here's a couple more. One, in fact, a meta-analysis that show stone-free rates will be better in the prone position. And I think the reason is you've got more access to more of the collecting system, ability to put in multiple tracks if you have to, so you've got better stone-free rates. Arthur Smith actually showed that it was more expensive to put people in the prone position. I'm not exactly sure what specifically accounted for the cost difference. I think it was shorter OR time mainly when you're prone, but showed that prone actually was less expensive. And one of the big things that comes up is anesthesia. I'm worried about putting people prone with the endotracheal tube, and you get into anesthesia problems. The best place to look at the literature here and the facts is to go to the anesthesia literature. And what has been found is that people ventilate just as well in the prone position as supine. In fact, one paper showed people actually ventilate better prone than they do supine, which takes away the whole issue about the anesthetic concerns. And finally, just some of our own data is just impressed, soon to be published, 2,600 cases, and not a single issue with the anesthesia, repositioning, or any problem in the prone position, which I think, again, supports this approach to it. So to finish off, if you're going to build a snowman, we think it's best to build it upside down. It works, it looks exciting, but the main thing is it works. So I'll leave it there. Thank you for your attention.